December's Geri Echo. My name is Sarah Tomkison, and I'm a social worker on the Geri Echo team. I just wanted to let everyone know that this CME activity is jointly sponsored by the Queens Medical Center and UH John A. Burns School of Medicine, Department of Geriatric Medicine. Joining me this afternoon are our interdisciplinary Geri Echo Hub team members. We have Dr. Lucas Morgan, Dr. Reese Ueno, Dr. Rita Bell Fernandez, and Chris Vale, physical therapist. We're excited that you're able to join us for our collective experience and wisdom and to learn alongside of you. As a reminder, evaluations are required if you would like to receive your CMEs or certificates of attendance. You can find the evaluations by following the link in the chat or at any time on our website and email advertisement. We currently offer continuing medical education for MDs, the DOs, RNs, nurse practitioners, and physician's assistants. Certificates of attendance are available for CNAs and students. Your comments are very important and useful to the planning committee for future programs. And this ECHO webinar is a forum of mutual teaching and learning from experts and from all of us here on the front lines. As the ECHO motto goes, all teach, all learn. And in the spirit of aloha, we encourage you to turn on your cameras to help us build this community of learning and engagement, and to still feel free to eat during this meeting because good nutrition is key to a healthy lifestyle. As a reminder, our ECHO webinar format consists of the following. It's a short lecture from our guest presenters, followed by open comments from the expertise of the ECHO Hub team members I just introduced you to. And you, the participants, your comments, your questions, your case examples for discussion are very valued. So we invite you to share any geriatric cases, but please keep case discussions HIPAA compliant. This includes not sharing um, the patient's name, their birth date, address, and so on. We learn best from our patients and our clients. They are our best teachers. Today, I'm very privileged to be able to introduce two of our guest speakers with just many years of experience in aging and healthcare field. And today's topic is home and community-based care, moving forward in Hawaii and the importance of caregiver education. I first would like to introduce Dr. Warren Wong. He was a physician at the Onlock Senior Health Services in San Francisco, Chinatown. Then he went on to become a physician for the organization-wide Kaiser Permanente Aging Network. And he also spent a year at the Institute for Healthcare Improvement as a Merck Fellow. Um, Dr. Wong is interested in active aging, the development of social networks, community development, technology, and the upcoming challenges for baby boomers. He's actually currently authoring the GOLD book, which the acronym stands for Getting Older with Love and Dignity. And this will be a handbook for caregivers. So we'll be interested to hear Dr. Wong when that will be available. Presently, he is a professor, clinical professor of geriatric medicine at the UH JAPSA. And he serves on the executive council for AARP and is on the Kapuna Advisory Board for Hawaii State Health Planning and Development Agency. The other presenter today is Dr. Jack Lewin. He has been appointed by Governor Josh Green as the President Administrator for the State Health Planning and Development Agency, otherwise known as SHPTA here in Honolulu. He's got a really big responsibility because he's charged with coordinating and development of a comprehensive healthcare reform strategy, which includes implementation plan for Hawaii that guarantees universal access, equity, affordability, and adequate and exemplary health workforce with high-tech and data-supported improvement in personal health outcomes and population health. Thank you, Dr. Lewin. So without further ado, that's a lot of, your plate is very full. So without further ado, let me ask Dr. Warren Wong to please lead us off.
Thank you. Let me start the slideshow. So we want to talk with you today about what Jack and I are ambitiously working on, hopefully for the next 10 years. And that is to have Hawaii be at the very front of the whole country in providing the best home and community-based care for our kapuna. And I would really want to tell you that this is not just a rallying cry, because we absolutely can do this. And I want to point out that we already stand alone as being the state with absolutely the best healthcare in the United States. And I'm going to show you a graph that points that out. So this graph is from the Commonwealth Foundation. The vertical axis shows the quality of care, and the horizontal axis shows the cost of care. And at the very top left-hand corner, you see one state standing alone with 50% higher quality of care than the mean of all the other states in the United States, and a mean of 37% lower cost of care than the mean of all the other states in the United States. And you can see we are all alone in the upper left-hand quadrant. So Hawaii is truly unique that way. Now that was data from 2015, and I want to show you that this continues to be true. You see the arrow at the left hand of this slide? This is again from the Commonwealth Fund. In terms of quality metrics, Hawaii ranks second in the country. And the bottom table shows cost of care for Medicare beneficiaries in the state of Hawaii. This data is produced in 2021 from the Kaiser Family Foundation. Hawaii is #1 in terms of the lowest average Medicare Part A and B costs in the entire country. So highest quality at lowest cost. And how do we do that? Well, part of the answer is here. Oops. Let me go backwards. We have among the lowest number of hospital beds of any state in the country. And the important point is that hospital beds are what drive up costs. We have fewer beds, and it makes an important point that the crowning glory of a healthcare system is not the medical center. Instead, we should really think of hospitalization as the failure of a healthcare system to keep people healthy. And underneath this is the wisdom of Shipta. And that's my very short introduction to a very close friend of mine who I've known for 40 years, Jack Lewin. I'll embellish on his biography. He was head of the Department of Health in the state of Hawaii. And at that time, he made it known that, correctly known, that Hawaii was the health state. And afterwards, he became CEO of the California AMA. Later, he became CEO of the American College of Cardiology. And the more interesting tidbits that I know about Jack is that He's a member of the 4 Million Mile Club at United Airlines, having flown all over the world, participating in conferences and giving talks. And another interesting tidbit is that he's a fellow of the American College of Cardiology, and he told me this, that he's one of the few fellows who ever became a fellow of the American College of Cardiology without actually doing a cardiology fellowship. So that's my intro to Jack. And Jack, I'm going to hand it back to you. But my question to you is, so what's the story? How did you end up back in Hawaii? And then maybe what the heck is SHPTA? Jack?
Jack, I think you might be muted right now. Thanks.
Thank you. Thank you, Warren. It's been a pleasure knowing Dr. Wong through all these years. He's an inspiration to me with his leadership in the whole gerontology field here in Hawaii and in other parts of the country as well. So, it's a real pleasure to see what can happen in a lifetime of commitment to something very important like healthcare. Our nation still hasn't achieved the notion of that everybody should be in. We all have access to healthcare, and it's something that society provides for all of its citizens, as almost every other developed nation already does. Yet we're still struggling with that whole issue. And being back in Hawaii is unfinished business for me because that's still yet to be done. We're ahead of most states in these regards, but all of us in the United States have a lot of work to do here. So, and I think that we're lucky to have Governor Josh Green, a physician and a kindred spirit, who is providing us an opportunity right now to take some steps forward as a state in health system reform. Obviously, homelessness and the problems of housing shortages are at the top of the agenda. The Maui wildfire crisis set the state back or put us on a new track of coming together to solve a crisis that we've all experienced. But we're on track to say to the rest of the country, we're going to come up with a model that might work for other states and then eventually for Congress, which is right now too divided politically to lead in this regard. So the State Health Planning and Development Agency was created over 50 years ago. I was still in medical training, and it's an agency which was kind of created as a health authority for healthcare oversight for the state. It never really got fully funded to fulfill that mission. It mainly now has been focused on providing certificates of need to certify that new investments in healthcare are coming from quality sources, they're needed, that they're appropriately designed and so forth, so that the state can maintain quality services, but also with an eye toward affordability. But the governor's expanded the notion of what SHPTA is going to do. And so we have embarked upon a number of new missions. We brought a bunch of experts together, including Dr. Wong, to have a Kupuna Advisory Council. We have a Keiki Advisory Council, a council focused on universal access to high quality, equitable, affordable care for every citizen, and a Health Data Advisory Committee looking at the sources of data that we need and that are available to use to monitor how we're doing. SHPTA is really at the forefront of this. Under SHPTA's authority, the legislature required all health insurers to provide us with the claims data, insurance claims data for all medical visits in this state, hospitalizations, emergency department visits, and doctor visits and other kinds of outpatient visits. We're collecting this data. We have the data for more than 70% of the population under management. We're going to add Medicare Advantage to that soon. And then there's still a small bit of work to do on some rather loose ends, but we're We're going to get all the whole population in. The data is de-identified and protected for privacy purposes, but it will help us understand and how to manage our future. For Kupuna, we would really like to see, as Warren stated before, a robust system of home and community-based services that allows people to age at home, and avoids the need for institutional care in nursing homes, care homes, or other facilities. Nursing homes are within 2 or 3 years will be $250,000 a year per person. They're currently over $230,000 a year per person. That cost is enormous. If we just took 40% of that or 30% of that cost and applied it to home and community-based services, we would have a fantastic opportunity, not only to save money, but to provide better care and to allow the ohana of our kupuna to really continue to work and do what they need to do while we care for our seniors in the community in a much more effective way. So let me kind of just sort of wrap up for a second, but I want to tell you that in the face of the Maui wildfires, a lot of the money that was really promised to me in returning to Hawaii, and by the way, I never really left. We've always owned our home here through all these years. Our kids grew up here. But I was on these adventures on the mainland, and I'm glad to have learned so much about the national healthcare objectives. And I'm bringing that information back here now to apply to the future in Hawaii of our healthcare world. We applied for a grant called AHEAD.
Jack?
And the AHEAD grant is really a goal. Yes.
I'll move the slides forward, but I
okay.
Thank
you.
Ask you this question. I know that 2 or 3 years ago,
yes,
you were living in a penthouse
overseeing Manhattan, New York,
Central Park.
Yeah.
When did so I'm really getting back to how you're back in Hawaii. When did Josh Green call you? Was it before he was actually numerically the governor, or was it shortly thereafter? Where I'm asking the question, how did you end up back in Hawaii?
Well, he called me out of the blue as lieutenant governor years back. I was the president and CEO of the Cardiovascular Research Foundation, attached to Columbia University in Manhattan, New York. And he said, Governor Waihee and I were talking. We think, you ought to come back, live in your house on Maui, and let's rethink Hawaii's healthcare future. And that was like, a number of years back. So on my visits back to Hawaii, which were frequent, I started going to see Governor Green, and we were talking about the strategies, plans. And when he became governor, we decided this was the best place for me to be, running the State Health Planning and Development Agency attached to the governor's office, working closely with MedQuest and the DOH and other government agencies, the Insurance Commissioner and others, to bring this vision about. So it's been in process for a number of years, and he and I have met a number of times, both on the mainland and in Hawaii, in preparation for this role I'm in. So anyway, let me just tell you a little about the AHEAD grant. The AHEAD grant is the federal government's strategy for trying to get states to do what the federal government hasn't been able to do, which is in some way or other fulfill a national strategy for health system reform, probably similar to what Bernie Sanders wants to do. But since that's politically very, very difficult, looking at the state level to make this happen. The AHEAD grant will pump a bunch of money into primary care. It's funded by CMS and the Centers for Medicare and Medicaid Innovation to expand primary care access and the funding for primary care, to change and improve the way hospitals are financed in the future, to incentivize them to be more motivated to improve the health of the communities they serve, to measure and monitor the costs of care across the whole state for all services, and to make sure that those costs aren't increasing faster than general inflation, to keep healthcare affordable, and to also focus on health equity and improving health equity for populations like Native Hawaiians, Pacific Islanders, and Kupuna in rural Hawaii. to bring them up the standards that we want in our state. That grant is a 10-year grant. It's in the pre-implementation phase right now. And the MedQuest agency and SHPTA were co-applicants. We were very, very happy to be among the first 4 states to be awarded the grant. Currently, there are 6 states in the grant. It will give the state about $12 million over 5 years for our administrative costs, but it could bring hundreds of millions of dollars to the state, to doctors, hospitals, and healthcare providers if everybody participates. So it's a really big deal, and we're very fortunate to have it. Some of the model objectives are there. It's a cooperative agreement between CMS and Hawaii. We work together on what the objectives are. The hospital global budget portion is the way some Eastern states pay hospitals now, the way Kaiser pays its hospitals, rather than fee-for-service or DRGs. We're working on strategies for how that could work in Hawaii, and then primary care ahead with incentives attached to patients to improve primary care, to make sure that everybody has behavioral health and social determinant screening, and that we're taking care of those problems in addition to making sure we have access. At the beginning of this, workforce shortage was mentioned in the introductions. That's one of the big problems we need to address here. But we need new delivery models that help us using technology like telemedicine and other new tools to get through this process until we can train up enough people. So new delivery system models are part of ahead as well. I'm going to stop there because I know there'll be a lot of questions about the grant. It runs through 2035, so it's a significant long-term process for us. The other states are Vermont, Rhode Island, Connecticut, Maryland, the New York boroughs on the outside of the Manhattan, not the whole state, and Hawaii, the only state that isn't up in the northeast corner of the country. So we're very excited about this and look forward to its implementation 27 to 2035.
All right. Well, thank you both for opening this up and sharing some of these very exciting, plans for the future for Hawaii's healthcare. Yes, and I'm sure there are questions and thoughts that we might have for you too, since we have.
By the way,
have you.
There's one slide here shows the ultimate goal for what CMS would like to see with AHEAD, and that is that we improve population health. We continue to do that, but we do it at lower state costs. So in other words, if the AHEAD model works, the cost curve that you see on the graph in front of you will slow. So the cost will increase slower than general inflation and promote affordability in healthcare. And that's what feds want to see. But the grant is intending not to just work with Medicare and Medicaid, the 2 programs the feds fund, but also to bring the private employed population and commercial insurers into the model as well, so that at the end of it, Medicare, Medicaid, and commercial insurance pay the same amount approximately for the same service, so that no patient is disadvantaged for participating in a program that is underfunded, like currently Medicare certainly is in Hawaii, and Medicaid is also on the low side of what the feds provide in terms of per capita spending in many other mainland states. And so, we are also, I think, a subject of inequity ourselves in terms of the amount of funding that the federal government offers us, given that we are the most expensive state for cost of living and housing in the country at the same time. So I think that we're a little bit shortchanged in terms of our per capita funding.
Jack?
Yes.
I was having a little bit of tech difficulty screen sharing, but I'm going to go through the AHEAD slides. And do you see the AHEAD slide in front of you now?
I do.
Do you want me to stay on this one, or do you want me to go to the next one?
I would go to the next one because I've covered those topics there.
Okay.
and that we've covered that one. We're slow the growth. The shared goals are, for all payer primary care investments, build on progress that we're making now, include flexibility, and leverage new tools for increasing accountability to increase the primary care investment. We want to make the primary care investment in the 10 years of ahead from approximately 5 to 6% of total spending to 12% of total spending. That's a 100% increase. We know that's going to reduce unnecessary hospitalizations, emergency department use, and improve healthcare outcomes if we do that. And so that's a bold challenge, but a significant part of those additional resources can go to home and community-based services for our kupuna. So that's very important in terms of this program. The cost growth target and the target program is something that Shifter will be managing. We'll be measuring our total cost of care and reporting every year on how those costs are doing in terms of the increases as compared to general inflation. The idea is see if we can keep healthcare inflation and general inflation approximately equal, so that healthcare isn't becoming less affordable.
So, Jack, the AHEAD money was sent to various states to create initiatives in states. How many states were given AHEAD funding? And can you give us a little bit about the timeline?
6 states only, and that's the end. That's the total. It's in total. The total enrollment is done now with the 6 states I mentioned: Vermont, Rhode Island, Connecticut, Maryland, New York, and Hawaii. And so the grant, it has a planning ramp up that goes from now all the way to January of 2027. After the planning is done, the grant gets implemented and the money starts flowing to hospitals, doctors, medical groups, and care delivery systems, including home and community-based services. That's where the main funding is really going to be if we get full participation. That starts January 2027, and it runs through 2035. So it's a long grant because the goals of the grant are very ambitious. And at the end, we'd like to have an all-payer system that looks like a true system for all citizens, where everybody's, when you switch from Medicaid to commercial or commercial to Medicare, it won't matter because your doctors and hospitals will be paid the same in all 3 programs. There'll be no stigmata attached to different sources of funding, and everybody will be, even though the sources will be different. Medicaid remains state and federal, Medicare remains all federal, and commercial remains employer and employee funded. So that's all. The funding sources are different, but the system will look the same, and everybody will be treated in essence equally. So that's the goal.
Jack, the AHEAD grant, how much money does that mean coming to Hawaii?
For the administrative part at the state level, $12 million. For the state itself, to the healthcare system during the grant period, to make these changes and make the improvements and streamline the system, the amount it's not unlimited, but it could be in the hundreds of millions of dollars a year if everybody participated. So the money coming to the state is really planning, actuarial, consultants. The big money in the AHEAD grant goes right to the hospitals, doctors, FQHCs and community clinics, medical groups, and other providers, behavioral health and social determinants as needed during the course of the grant.
So I'm going to take over now, Jack.
Thank you.
And talk a little bit about the Echo Lecture Series is about healthcare for seniors, and we all know that healthcare is not designed for seniors. And I'll make a case in point. We all know what Kapiolani Medical Center is. It's a hospital for children. And all across the country, we have a healthcare system that in all major cities, there's a hospital, a children's hospital in the major urban centers. And Kapiolani's others, of course, in nowhere in the country is there care that's specifically well designed for seniors, especially frail seniors. And the way I see things now is we have a long way to go in home and community-based care. It's about where nursing home care was about 30 or 35 years ago. There was a story I remember from when I used to live on Maui and I was at the nursing home at Halimekua. The chief administrator told me that care was terrible for seniors in the nursing home. And the example he gave me was that one patient had not been seen by a doctor for the entire year. Even as the patient got sick, treated with IV antibiotics and everything else, the physician never came once. And we all know that nursing home care is much better now, which is why I'm stating that home-based care is where nursing home care was 30 years ago. And that's why it's very exciting to be involved at this stage in the evolution of home and community-based care geared for seniors. And I see it as a very important time because we know that we have an aging, frail population. There's a very specific meaning related to the new emphasis in the Trump administration for cutting costs. There are certain programs that are not going to be cut. Medicare is not going to be cut. Social Security is not going to be cut. But almost assuredly, there's going to be a look at Medicaid. And where is money not well spent within the Medicaid system? And Jack already pointed that out. We are spending $200,000 per person per year in a nursing home in the state of Hawaii. And so we can definitely foresee that Medicaid's going to look very carefully at how money is spent for frail elderly. And it's clear that there will be an emphasis on decreasing nursing home stay. The other important thing is the gap group that we all know about, people who don't qualify for Medicaid, and they are under serious threat as increasing care of frail elderly needs to be in the community. So I wanted to point out some bright spots as we're at the very beginning stage of evolving home and community-based services for frail elderly. And one element that we feel is essential is the community health worker. And the community health worker, the work that Dr. Fernandez has done is really about addressing the massively important social determinants of health. And we in the geriatrics field all know that it's not about picking the best drug. It's about making sure that the caregiving situation is as good as possible. And those are all about social determinants. So I wanted to give you one example of a bright spot in Hawaii. And that is Kalele Wellness Advocacy, which is based on Maui. So they have started using community health navigators at Maui Memorial Hospital. Maui Memorial Hospital identifies patients as soon as they're admitted who are very likely to end up needing post-discharge care, very likely in a nursing home. And the community health navigator begins being involved at the point that they're in the hospital. The community health navigators, and Jack and I both used to work on Maui, they know every ward at the hospital. They're there every day, and they introduce themselves to the patients while they're inpatients. They follow them through the nursing facility, which on Maui is most often Halemakua, and they will follow them for up to 60 days post-discharge. And the community health navigators do everything from emptying the garbage to helping patients contact providers and to working with support services. And these community health navigators are not, come from varied backgrounds. They are not RNs nor social workers with those types of formal credentials. And the data so far in a longitudinal series is that the people who have received the services of these community health navigators who describe themselves as a friend of the family has resulted in decreased length of stay, reduced length of stay in the SNF, and decreased rehospitalization rates. They are now spreading to Kauai, and in the future will also be spreading to Oahu. And I've already talked with Dr. Fernandez about a formal presentation to your group from this group. So aside from community health workers, another key intervention is technology. This slide that I'm showing you now is the slide that portrays the way people have private paid for home care services. It's always and what that means is the average home health aide sees 2 clients a day. And even as my own patients who had dementia would ask, why do they need so many? Of home health aides is 20 clients per one person, and they are assigned geographic areas, and they are tech enabled to make most efficient use of their time. So Vivia Care likes to point out that their shortest visit is 5 minutes. And that is for med administration. And there is no 3-hour minimum. And this kind of technology advance is what we're seeing as one vital piece of what we're doing as we evolved into home and community-based care. Another question is, how do you pay for home and community-based care? And I think most of you are already familiar with home-based palliative care, specialized medical care using nurses, nurse practitioners, healthcare providers, social workers, and home health aides provided by hospice. But home-based palliative care makes the point that these patients are not on hospice. They can continue. The model is not either or, it's both and. And this was work that was actually originally started at Kaiser, but then Dr. Sykes developed it at HMSA with their supportive care program. And HNA also has the concurrent program, which all have the same concepts. And the important point is that we are the first state in the country that will make home-based palliative care, home and community-based palliative care, a Medicaid benefit. So you're reading the second paragraph. CMS recently announced that Hawaii is the first state in the nation to offer a palliative care benefit for Medicaid recipients. I also wanted to point out another innovation that is nationwide, but that exists in Hawaii as well as the veteran-directed care. Veteran-directed care means that the veteran system identifies people who are nursing home eligible and living in the community. In the state of Hawaii, the veteran system will refer those patients to the Executive Office on Aging. The Executive Office on Aging uses vendors to do an evaluation of every veteran to determine what their needs are and to make assure that they're nursing home eligible living in the community. And the vital distinction of the veteran-directed care is that after the evaluation is done, uh, a a veteran who qualifies for the benefit is given a monthly allocation. In the state of Hawaii, it varies somewhere from $2,000 to $8,000 a month, and the veteran himself or herself, together with the assistance of a care coordinator, decides what services and who to provide those services. And this can include paying for family and friends to provide the services. So this exists around the country, but exists and is alive and doing well in Hawaii as well. And this describes some of the features that I pointed out. So these are some of the bright spots. There are many more bright spots in Hawaii that are amazing, but because of the limited amount of time, I wanted to point out some innovations related to community health workers, technology, and providing coverage services for the home and community. And that's the end of my presentation. We're very interested in questions that people raise.
All right. Thank you very much, Dr. Wong and Dr. Lewin. And we want to, use this time to first open it up to our panel and then to folks, other attendees with any questions. So, Sarah from Social Work, any thoughts or questions?
Yeah, I think congratulations on being recipients for the AHEAD grant. And I guess that just a couple of questions that came to mind. I really appreciate Dr. Wong that you spoke about a number of innovative programs, and there's probably a lot more. And so there were two thoughts I had. One, I wish that there was a community clearinghouse specifically for home and community-based services. I say that because oftentimes when clients or families call the Elderly Affairs Division, for example, it's a very daunting task to try to maneuver and figure out what services they get. And most people aren't aware to even ask if the client is a veteran. But the second question has to do with how and who will you partner with to implement the AHEAD program? Because there's so many different HMOs and there's the providers, the healthcare providers, but how do you envision doing this implementation as you partner?
Jack, I'll let you answer that second question, and then I want to circle back to the first question after you finish.
I was going to just say, well, in the Medicaid program, the purveyors are HMSA, Kaiser Permanente, Aloha Care, Ohana, and United Healthcare. So there are 5 contracted parties. Ironically, those same 5 contracted parties provide Medicare Advantage in the Medicare space as well. We will clearly have to partner with all of them on both sides. In Medicare, however, there is about 40% of our beneficiaries have chosen to stay with traditional Medicare, which has no insurance company attached other than the Centers for Medicare and Medicaid Services, federal government. So for those folks, we need to work with the doctors and the hospitals and caregivers, the FQHCs, the community clinics, and so forth to reach them. But we're going to be partnering with hospitals, with physicians and advanced practice nurses, and frankly, with all the entire health sector, if we take full advantage of AHEAD. So the insurers are going to be involved, hospitals be involved, and the clinicians and providers will have to be involved. Organizing that is going to be tough. We have 2 years to plan for it, and then 8 years to actually deliver. At the end of that, we should have that all-payer system built so that we're in a whole new world.
Jack, isn't it true that it's yet to be seen who wants to play and who doesn't want to play?
Yeah, it's totally, there's no requirement that people play, but there are financial incentives for those who do.
Yeah, that was the follow-up question, is how would
It's
you
completely,
incentivize?
no one's forced to participate in AHEAD. The idea is to make it attractive enough that everyone wants to participate. For example, in the primary care Medicare side, there'll be $200 per beneficiary added to whoever's the caregiver taking care of those patients. So if a group of doctors has, let's say they have 1,000 Medicare beneficiaries, then they'd have $200,000 to improve services for those beneficiaries and focus on the ones who need the services, because we're going to need data to support what we're doing and identify the people at risk if we want to keep people out of the hospital, out of the emergency department, and if we want to slow the progression of chronic disease in these patients, which we do.
Jack, what is the per provider per month incentive for physicians who participate?
It's not, there's no provider per month. The money is attached to the patient. So for every Medicare patient that you're taking care of, you're eligible for increased reimbursement for that patient. If you're an AHEAD participant, if you're a hospital, and you can get now new rewards for improving equity in the community, for reaching to people who didn't have services, for improving the population health in your community, and for avoiding unnecessary admissions and emergency department visits. Hospitals will get incentive payments as part of the hospital global budget transformation.
Sarah, I wanted to go back to your first question. And we all have our impressions about the Executive Office on Aging and the area offices on aging. The area offices on aging actually vary quite a bit from island to island. The Executive Office on Aging, I think the jury's out. Certainly historically, it's what it's delivered has been probably not great, but the budget and staffing has actually improved, and the jury is out related to that. Now, that said, there's people in the audience who are interested. There's a platform called Unite Us, and you were talking about kind of a community-based caring house. And Unite Us is not community-based, but it is a software package that is used by Queens and Kaiser and is used nationally. And that software package is being integrated into Epic, which basically looks at social determinants, identifies social determinants, keeps a database, and records in the Epic results of interventions. related to people who have identified social needs. I also talked with Project Donna yesterday, and the staff at Project Donna, some of them don't want this to be known yet, but other people are very enthusiastic. Is that Project Donna is using a software called Mon Ami, MONAMI, which is a software that's used across the country, which will connect community-based volunteers with matching the needs of people, seniors who live in the community, seniors who are frail or disabled, and creating a database of matchup. And the Monami is going to be used more in social care networks than it is in healthcare networks. But I think ultimately we're really interested in dissolving the silos between social care networks and healthcare networks.
Well, thank you both for those details. And Sarah, for your question. We are coming down to the last 5 minutes of our time today, and I know everybody has a ton of questions, and we're going to use the last few minutes for what we can. Just want to remind folks to click on the link that John helpfully just posted in the chat box to complete the evaluation in order to receive your continuing education credits. So make sure you go ahead and do that. And yeah, there's a bunch of questions in the chat box. Sarah Roxell asks, how do we stay in the loop and how to apply? So where to get more information as providers, maybe as organizations, and how to apply for that participation.
Okay, well, for the head grant, we will be reaching out during the next, between now, this year and the following year, 2025 and 2026, to get people to sign up. You literally have to, as a hospital or as a physician or as an advanced practice nurse or as a health center or clinic, you need to say, I want to participate in a head and actually sign up for it. We'll be helping people do that. We have 2 years to get people engaged, and then you become eligible for the incentives and incentive payments that are involved in the program. And remember, it's entirely 100% voluntary, but it's a really an exciting way to look at moving from where we are to a more a better kind of health system future for Hawaii. So we're hoping that we get significant participation across the whole health sector.
Thank you for that. And just a follow-up question with that, how would sort of like a private practitioner in the community find that advertisement and sign up, for example?
Well, we'll be putting that out. We're also going to have consulting partners who are going to reach out and actually enroll people like that, help you do it. That's one of the consultants that we'll have there, which is to bring people, bring clinics, doctors, advanced practice nurses, and other clinician providers into a head. If you were part of Queens Hospital or Hawaii Pacific Health here, and your hospital decides to participate in the hospital global budget, you'll automatically get enrolled as a clinician in the program on behalf of your patients.
Will allied healthcare professionals like psychologists
Absolutely,
be eligible?
yes.
Yeah. Okay.
Yes,
great.
they will.
Yeah.
In fact, we need them. We're going to need more behavioral health than we have. So we probably will have to borrow people with telemedicine from West Coast from time to time, really, to meet the need.
Sorry, go ahead, Dr. Wong.
I saw a question from Dr. Wen
Wen.
in the chat, and she talks about staffing And of course, GWEP plays a very important role in that. We do think that community health workers are going to be vital. And we talked with the Hawaii Health Institute about the Kapuna Navigators program, and they've actually started training over 100 community health workers. But there is a crying need for them. And I think on a more aspirational level, I brought up the comment about volunteers. There's a vast potential pool of volunteers. How to organize volunteers to assist people for simple tasks like, and we already know some of the tasks they're involved in. It's transportation, delivering meals and things like that. But there's a vast potential for volunteers. Organizing that it will be daunting.
Definitely, that's a huge problem. And Sarah, did you have something you wanted to follow up with there?
Yeah, I think the biggest place where we have a huge staffing crisis is really home health worker, like beyond the navigators, that's going to be great. But when you say expansion of home and community-based services, we have got lots of people that qualify under those programs right now that they cannot get. The thing that is going to keep them out of the hospital is the person showing up to do the care, and they simply can't be staffed. So to me, I haven't known anything about this program, but $12 million is going to disappear really quick if you're going to give everybody $200 a month.
The $12 million doesn't contribute to that.
Okay.
No, the $12 million is strictly to the state. The $200 is coming directly from CMS to the doctors or to the providers who have the patients.
So, but the place where those of us boots on the ground doing this work cannot get the care for the patients in Hawaii is that we don't have caregivers who can do the care.
Well, so that's where we really, one thing we need to do is develop more, we don't have enough community health workers or navigators either, right? So what we need to do is consider training programs for early retirees, volunteers from churches and community clubs and associations at community level who could be high touch sort of people with a device that they can link the patient up to the nurse or to the doctor when needed without having to transport them. So there are lots of things we can do to think about new ways to approach the health delivery for patients.
I think the biggest thing is that these jobs not the navigator part. The navigator part is great, and there's going to be lots of volunteers, and there's a whole pool of people for that. What we don't have is the young, able-bodied people who are able to turn a patient in bed, who are able to prep a meal, who are able to do the physical labor and get paid enough to be able to feed their family. Right? That the turnover is insane. Nobody is willing to keep the job. Like that is the piece where we incentivize Medicaid here, or incentivize the whoever, like the agencies, to pay enough money to these people so that they actually want to keep their jobs and we can build a workforce. Because none of this it's all going to fall apart if we don't have those bottom boots on the ground people doing the physical care for the patient. It's not the lack of doctor care.
And we totally agree with that. So for people that need to be turned, and that's going to require an aid. But remember that if we were to take, let's say we took 40% of the $230,000 for a nursing home average placement, and we provided $100,000 of care for people who are eligible for skilled nursing or nursing home care. They're eligible. But instead, we provide the care at home. What if we provided $100,000 of care, saving like 60% of what we would otherwise spend? That would be $300 a day to have people come in, provide a whole array of services. Full-time aid for 8 hours while the
Sure.
family's working.
But we don't have those aides to staff those out. That is the critical
Yes.
shortage that everybody on this call who actually does work in this field is nodding along and having thumbs up
Yeah.
reactions to. There
Yeah.
are not the people here in Hawaii to do that work.
Sarah, can I
We
make
can
a
throw
comment?
all the money in the world at it, but we don't if we don't have the personnel to do the work, this program isn't gonna work.
Sarah, can I make a comment? Can you hear me?
She's on mute. Dr. Roxa, you're on mute.
Yeah, so that's one reason that veteran-directed care is kind of an interesting concept, and Quest does it to a very limited extent as well, just to actually pay family members to provide some of the care. And realistically speaking, the care home industry is going to expand. Uh, in support of the care home industry, uh, they will be able to provide uh, the hands-on care at a lower cost than nursing facilities.
And that's an issue too, right? Because one, Medicaid doesn't pay for care homes; they pay for foster homes. Foster home caregivers are paid $24 a day, right? So like this, where these monies need to go is into the infrastructure of delivering the care. Nobody's saying that we want to put people in nursing homes. We don't like that model is not something that's going to happen in Hawaii. But we have people that do not. They are giving 24-hour care to patients and not. They are losing money on the Medicaid beds. So yes,
This,
the
Hi, I'm
state is
so
saving
sorry.
money,
I
but
am sorry, so sorry to interrupt. It's
thanks, Jesse.
106. I know this is such an engaging conversation. John had put the link to the evaluation in the chat. If the guests are willing, I know they're busy. If they're willing to stay on and answer a few more questions, they're free to do so. But for everyone else, the evaluation link is in the chat. So please do that in order to get your CEs. Thank you.
Thanks, Jesse.
Sorry to interrupt you, Rebecca. Sarah, sorry.
Well, there's two Sarahs. Is there any way, Dr. Wong or Dr. Lewin, that if people want to be a part of a council, I mean, I think there's there might be people in the audience actually from other agencies that would like to be able to help, contribute whatever their experiences have been in this area. So do you have people that can do that?
SHPTA has the Kupuna Advisory Council, and it's got some very brilliant people on it, like Dr. Wong and others in the gerontology field that would welcome we would welcome your participation for anybody that's interested. You're welcome to come to the meeting. Anyone can participate. If you'll just send us your interest, we'll add you to the list and make sure you're included, and you'll be welcomed. So
Thank you.
Where
that's
can
Thank you,
they
something.
find
Dr.
that?
Lewin.
Yeah, that's something we can do here at SHPTA.
Wonderful.
Where can they find that, Dr. Lewin?
They can send a message to Wendy Nihoa. Wendy can be reached at wendy.nihoa, Nihoa, at doh.hawaii.gov. I'll put this in the chat.
Thank you so much.
Yeah.
It would be nice to have other clinicians participate, like the psychologists,
Yes.
yeah, and the nurse practitioners.
Yes, it would be. And we have some already involved, but we welcome more.
Are there any comments out there about that pressing issue of getting workers?
Pardon? Is that asking me, Warren?
No, I'm asking the audience.
Yeah.
Yeah, there's a lot of comments in the chat, Dr. Wong. At least half of that's the biggest challenge that Dr. Roxa mentioned, but it's the same challenge for everybody else. And where they work, whether it's a community clinic or the hospital, is trying to find hands-on caregivers. Any other? I'm just facilitating because Lucas has to leave us. Is there anybody else that has comments or questions for Dr. Wong or Dr. Lewin before we close?
I just want to say that's super exciting.
Dr. Tom says it's a buyer's market too. Everyone wants the popo, which is your Chinese grandmother who's sweet, nice, and weighs 80 pounds. Thank you. All right. Well, thank you again, Doctors Wong and Dr. Lewin, for your presentation. And we look forward for you doing a follow-up with us maybe next year in January. What do you gentlemen think?
That'd be wonderful. Thank you.
Sure.
Okay, thanks everybody. Take care.
Hello.